Thank you. All the following statements about non-antibiotic antimicrobial biocides are true except biguanides are cationic, interact with phospholipids, disrupting the membrane. The quaternary ammonium compounds are cationic surface active agents. Disinfectants, antiseptics, and preservatives tend to have specific targets of the action. Organic compounds of mercury and silver ions are less toxic than their inorganic compounds. All the following are true except
I think okay. I think B is true. I think we can eliminate B, that the quaternary ammonium compounds, it's true that they are usually cationic surface active agents. So I think we can eliminate B.
I think even C is true.
Disinfectants and tend to have specific targets of action.
Ama?
I don't know about that. I don't know about that.
Or not sure even.
Liz has said that C is true without a shadow of a doubt.
How about D?
Even me, D, I was like, are mercury and silver less toxic than the inorganic compounds? Okay, feels that mercury is toxic. She feels.
Yeah, I think D is toxic because if you compare inorganic mercury salts, the most toxic form of mercury is usually which is forms more toxic than the inorganic ones, because I think the inorganic ones that are silicas natumeka for filling the teeth, they're usually less toxic compared to the organic forms. So D is false.
Yeah. That's true. Yeah, that's true. I'm finding here that just a statement from the textbook Pharmaceutics Dosage Form and Design about the organic mercurial compounds, that these are antimicrobial agents that contain mercury, and due to environmental and toxicity concerns, they are no longer used. So yeah, they are very toxic.
Mr. Maloney, Georgia. Thank you for coming here.
Then just as a small note, that mercury can cause neurological damage after passing the blood-brain barrier. It can cause neurological damage after passing the BBB. What about disinfectants and antiseptics? Which one were for the surface and which one were for us for living bodies?
Disinfectant is for surface.
Or disinfectant is for surface.
Yeah, the other one is for wounds.
So humans, we use antiseptics.
Yeah.
Disinfectant surfaces. Then biguanides are cationic, interact with blah blah blah. What's an example of a biguanide in this scenario? Like Biguanide and
Okay, we can
Chlorhexidine.
say that's for me.
ChatGPT is saying chlorhexidine is an antimicrobial biguanide, which is
Uh-huh.
used as an antiseptic and disinfectant.
Chlorhexidine.
Yeah.
Nice. Then maybe on this note, I don't know if you guys covered it yesterday. Have we looked at preservatives, maybe preservatives and
No, we haven't.
so we can cover preservatives real quick.
Take us through.
See if I can get a summary version of this book. Let me see. Or you can be saying at least what you know about preservatives, examples of preservatives. Then we can also just look at the surface active agents also.
Okay. Preservatives are chemical substances that are used to prolong the shelf life of pharmaceutical products. And they can be used as an additive for foods or pharmaceutical personal care products, cosmetics, and other industry. The why we use preservatives in pharmaceutical preparation is that there's 3 reasons for that. The first one is to stabilize the product, to preserve the product during shelf life, and to preserve the activity and efficacy of the product, of the drug. And then the preservatives are of 2 types, antimicrobial and antioxidants. And then this classification of antimicrobial preservatives, there are parabens like methyl paraben, butyl paraben, ethyl paraben, and then there are acids and there are salts like benzoic acid, quaternary ammonium compounds like benzyl alkonium chloride. And then there are ones which has mercury like phenyl mercuric acetate. Yeah. And then the ones that have alcohol, benzyl alcohol, the ones that have phenyl, 4-chloro-3-methylphenyl, and then biguanides, chlorhexidine. Yeah, that's the pretty much summary of it. Every like
Nice. I think Basi, you've covered everything, and Samia is adding that benzalkonium chloride is used as a preservative, usually in eye drops. The benzalkonium chloride, specifically in, or more commonly in, eye drops. Yeah. Then active agents.
I'll share with you this notes. It's from Dr. Yasod. I'll share it in the group. It's one of Dr. Yasod's notes.
Nice. Surface active agents. Anyone with something on surface active agents? Where they usually use anything you know on surfactants.
Okay, the surface active agents or surfactants are compounds that lower the surface tension between two substances, such as liquid and a solid or liquid and a gas. And they have molecules with hydrophilic and hydrophobic parts, allowing them to interact with the different phases. I consider some applications of surfactants here. They use as detergents, emulsifiers, foaming agents, wetting agents, biological applications. For biological applications, they're used in pharmaceuticals and cosmetics. They also play a role in biological systems such as functions of cell membranes. That's what I've Googled, but I don't have any much information.
Okay. So yeah, that's she's talked about the uses, examples. Yeah, but maybe something to add is that the surface active agents, okay, they're also called surfactants, hydrophilic group and a hydrophobic group. That's why you see even Shafi has mentioned that it's essentially it is applied in the plasma membrane. We know the plasma membrane is made up of a hydrophilic head and a lipophilic or a hydrophobic chain. Then in pharmaceutics, we classify them based on the charges. We have the anionic surface active agents. And these anionic surface active agents, the most common one, even in the industry, is the sodium lauryl sulfates. Okay, so these are usually the sodium and potassium salts. Yeah, so sodium lauryl sulfates. When you see there's a sodium or a potassium, then there's a fatty acid and a salt that is more likely to be an anionic surface active agent. Yeah. Then we have also the cationic surface active agents. Now, cationic surface active agents, the advantage is that they are bactericidal agents. They are bactericidal agents because they will absorb onto the negatively charged surfaces of the bacteria of the wort. Yeah. Then usually here we have now the quaternary ammonium compounds. These are the ones that are mostly used. So here you'll get things like the benzalkonium chloride. That's you can see it's a ammonium. It's a quaternary ammonium compound. Non-ionic surface active agents. Non-ionic surface active agents. So from the name, you can just tell that this one has no charge. And the types here, we usually have the polyoxyethylene. Yeah, those are the common ones. Then finally, the Zwitter ionic surfactants. Yeah, Zwitter ionic, basic charge at the end of the day is a balanced charge. The positive and the negative, they balance out each other. Yeah, so the Zwitter ionic is usually a good one because I know it is compatible with both the cationic surface active agents and the anionic surface active agents. So perhaps that's all I can say on surfactants. If nothing else to be added, we can maybe move to the next question. And it reads, what's the name of the biocide? A below. Okay, has already tweeted and said this is chlorocresol, which is a disinfectant. an antiseptic and a bactericidal compound. It kills bacteria, prevents microbial growth. It's also used in various pharmaceutical products to increase shelf life. So it's chlorocresol. Nothing to add, then we can go to the next question.
So we can say that antiseptics and preservatives are kind of similar.
Black Panther is saying she can't hear anything.
Can you guys hear me?
Yeah, Hiral, we
Yes.
can hear you.
Yes,
Oh,
we
okay.
can hear it.
Yeah. So like antiseptics and preservatives. Sorry?
I've muted this clown. Go on, Hiral. Go on, Hiral.
Yeah, so my question is antiseptics and preservatives are similar. Because if we're looking at their classification, they're the same.
Antiseptics, what I know is they are antimicrobial substances that are applied to living tissue, like on the skin or the mucous membrane to reduce the infections. But preservatives, they are added on the pharmaceutical preparations. So how are they saying? Or I'm wrong, I don't know.
As in like when you're looking at the classification, like the picture that I sent is antiseptic and disinfectants. And the presentation that you've sent has like the same classification. Like not same, but like similar. For example, the chlorhexidine is also a preservative and it's also a disinfectant or an antiseptic.
This slide you've sent, it's from disinfectant.
Yes, antiseptics and disinfectants.
Okay, I don't know. Able share the whole document. You can
Okay.
see the difference. Because I think preservatives only for the chemical substances, just to prolong the shelf life of pharmaceutical products. And then
Yeah,
antiseptics.
that makes sense that preservatives are used for like formulations, but I'm just asking, like, they do the same job, right? It's the same action.
I don't know. Okay,
I
guys,
think,
help.
no, I think, yeah, it's just how they are used. If it's used topically for a wound, it's an antiseptic. If it's incorporated into a drug, it acts as a preservative. But the basic mechanism of action is the same, being bactericidal. I think now it's based on how it's used, but it can act as both.
Thanks.
Yeah, but those are my thoughts. I know we have a very good industrial pharmacist here by the name of Devayani. Maybe she knows best.
Viral, what was your question?
My question is antiseptics and preservatives have like the similar action, right? Because they're used as both.
I think antiseptics kill bacteria that is already existing, and then preservatives prevent them from growing. Something like that.
Yeah, that makes sense. Thank you.
You're welcome, Miral. Anytime. So we can move to the next question. Someone has something to add?
I think I wanted to say something, but it was for the previous question. I found a nice document. I'll send it in the group, the one for it's just talking about a summary for the surfactants, the surface active agents. I think the only thing, it's a bit long, so I think the only thing I saw that maybe I think is relevant to mention. So for the surfactants that has the most relevance in the pharmaceutical industry are the non-ionic surfactants because they are commonly used as emulsifiers, wetting agents, solubilizers, and dispersants. And also in the manufacturing of creams and suppositories, they are used as gelling agents and forming agents. So I think when you compare with the cationic, the anionic, and the zwitterionic, the non-ionic are the ones which are heavily used in pharmaceutical formulations. And this document is saying, I'll send it to the group, that the ones of the most common anionic commonly used anionic surfactants, there are two. There's the sorbitan esters, which have a low HLB value, the one we talked about, I think, when Diana was taking us through pharmaceutics, which are used for now the water in oil emulsifiers, and then also the ethoxylated anionic surfactants, which have the opposite. They have a high HLB number. But I'll send it so that you can read. It has put in a very simple way. I think I just wanted to highlight that anionic surfactants are very relevant as emulsifiers, wetters, solubilizers, and dispersants in the pharmaceutical industry. Yeah.
Thank you so much. Thank you so much, Dr. Non-ionic surfactants. Yeah. So, yeah, please send the document. Anyone with anything to add? Okay, so we move. That which one of the following antifungal agents inhibits microtubular functions? Which one of the following antifungal agents inhibit microtubular function? So, okay, is asking if grisans and griseofulvin are related, then grisans is the answer. I was also thinking the same. Anyone of a different opinion? So I think for 97, we can go with B. And then just quickly, we can have someone cover antifungal drugs, pharmacology of antifungals. These are places we wouldn't have reached if we are doing systemic reading. So just someone can cover the pharmacology of antifungals. Or any antifungal, you can start with the common one, fluconazole. We're always giving fluconazole. What do you know about fluconazole?
So I was thinking maybe we can just start with classification, like maybe we can cover a bit of medchem kind of thing. So in antifungals, we have antibiotics, yeah? So they can be of choline, which you can remember with the short form of NAG. So N stands for nystatin, A stands for amphotericin B, and G is natamycin or griseofulvin. Then we have allylamine drugs like terbinafine and naftifine. Then the azole derivatives, we can have imidazole, which include clotrimazole, miconazole, then ketoconazoles. In triazoles, we have fluconazole, itraconazole. Thiazoles, we have abafine, and nucleoside antifungal, you have flucytosine.
Mm-hmm.
Then maybe somebody can take us through like through a diagram, something to remember the mechanism of action. If somebody has a summary for all. I think in Hermias might have shared. Let me check.
Yeah. Let me also share a picture
There
to the
is,
group.
sorry.
Yeah, Hiral, go on.
There is also echinocandins like caspofungin, which is fungistatic. And then I think flucytosine is also used as an antifungal also.
Mm-hmm.
And then you have other like drugs like benzoic acid and sodium thiosulfate that have these antifungal properties. Like for example, benzoic acid, it has like this keratolytic properties. So it can be used for this tinea infection causing like on the nails.
Mm-hmm.
And I think sodium thiosulfate is used against Malassezia furfur.
Nice, nice, nice. So we've looked at classification. We've talked about even the miscellaneous antifungal agents. So now can we go to the mechanism of action, side effects, patient advice, anything now? We can start with the polyenes. Starting with the polyenes, I think amphotericin B. Someone can say something on ampho B. It's the
Okay, polyenes, the mechanism of action of polyenes is they interact with the sterols in cell membrane, ergosterols in fungi. They react with that, and then they form a channel through the membrane that leads to the leakage of intracellular components. So they are fungicidal. And amphotericin B is an example. Amphotericin B is amphoteric. It has amphoteric properties, insoluble in water and neutral pH. It's obtained from Streptomyces nodosas, and then it binds to, I've said, to the sterol moiety, that's ergosterol, and then leads to the leakage of the membrane. So it disrupts the membrane function. And then when it leads to leakage of membrane, it results the cell death. That's how it affects the antifungals. And then amphotericin B, here I can see it's both fungostatic in clinical obtained concentration and maybe fungicidal, but according to the mechanism of action is fungicidal, but clinically it can be both fungostatic and fungicidal. And then it's used as a wide spectrum agent, aspergillosas, blastomycins, candidas, cryptococcus, as in you can use in name it all, even protozoa like leishmania, and then it's the most effective drug for various types of systemic mycosis, and it's the gold standard of antifungal therapy. So it can be used systemic mycosis, especially in immunocompromised patients. And then it's used in the treatment of pulmonary aspergillosis infection, used in blastomyces infection with a life-threatening HIV or CNS involvement. It's used in deep organ infection with candida. It's used in all streptococcus infections. I mean cryptococcus infections. There is a topical preparation that's used in cutaneous and mucocutaneous candidiasis. The the leishmania that is used, the one that's used in leishmania is the drug-resistant Kala-Azar and mucocutaneous leishmaniasis. You can use amphotericin B also. They are available intravenous injection and topical preparations. Yeah, let me look for drug-drug interaction with anything. Some of the ADR are acute reaction, long-term toxicity. There's like the normal ADRs, nausea, vomiting, fever that can last to 2 to 4 hours. And then thrombophlebitis of the injected vein can occur. I don't know what thrombophlebitis is, but if it occurs, you can add heparin to the infusion and it accelerates the problem. I think it forms a blood clot on the injection sites. So that's why we use the heparin to remove that problem. And then it says the mechanism of it forming this thrombophlebitis is due to the release of cytokines like L1 and TNF alpha. It also has nephrotoxicity is common with long-term administration of it. And the nephrotoxicity is dose-related. Yeah, the mechanism of it causing nephrotoxicity is the drug reduces the glomerular and renal tubular blood flow through a vasoconstrictive effect on efferent renal arterioles, which leads to destruction of renal tubular cells and disruption of the tubular basement membrane. For the management of nephrotoxicity, the patient with nephrotoxicity, we use normal saline infusion prior to amphotericin B dosing, or you can use a lipid-based amphotericin B products that utilizes and minimize the nephrotoxicities. That's pretty much all the ADRs I can see. It also leads to hypokalemia and hypomagnesemia. The wasting of potassium and magnesium in the urine secondary to renal tubular acidosis usually results in hypokalemia and hypomagnesemia. And then it leads to hypochromic or normochromic anemia, whereby it decreases the production of erythropoietin. The mechanism is unknown, but patients with low plasma erythropoietin may respond to administration of you can use recombinant erythropoietin management when you have hypochromic anemia or normochromocytic anemia. That's pretty much all the toxicities. And then you avoid, I've said it leads to nephrotoxicity, and the drugs like aminoglycosides, vancomycin, cyclosporin will lead and worsen the nephrotoxicity. And it can even lead to renal impairments when you co-administer them with amphotericin B, so you don't co-administer them with amphotericin B. Yeah, I'm finished.
Yeah, thanks, Shafi. Thanks, Shafi. I think she's covered everything on Ampho B. Next, under the polyene, someone can talk about nystatin real quick. Anything you know about nystatin?
It has the same mechanism like amphotericin B, and it's both fungicidal and fungistatic. And it's mostly used for Candida species.
Yeah, nice. Yeah, nystatin mostly it's the use that is unique for the oral candidiasis. Yeah. Black Panthers told us it's a category C in pregnancy. Next, we can go to the most common. Let's go to the azoles. Azole, what's the mechanism of action of the azoles? How are the azole classified?
Okay, so for azoles, the mechanism of action is just simply blocking the synthesis of ergosterol, which is the primary sterol in the it's a primary component in the cell membranes of fungal cells. Yeah, so that alters the fluidity of the membrane. And I think for classification, we've put it in the group. There's an image we've sent in the group, mainly into two, imidazoles and triazoles. The imidazoles are the three ones, at least they are familiar: clotrimazole, miconazole, and ketoconazole. And then for the triazoles, the common ones are fluconazole and itraconazole, but also voriconazole and posaconazole are there. Yeah, so I think that's for classification. I think the only thing that I know that is true, of course, can add. For fluconazole, I think it's when I learned from a patient during attachment. It's very teratogenic. Okay, at least I've confirmed, but especially in the first trimester, it's not recommended to give fluconazole unless there's a serious life-threatening cause for administering it, but not very safe during pregnancy. And for ketoconazole, ketoconazole I know is used to, especially the topical formulation for seborrheic dermatitis, which is one it's just a fungal condition of this. It affects the skin and the scalp, caused by the Malassezia fruit. So yes, I think anybody else can add any other special information for the azoles. Yeah.
Okay, for the imidazoles, they're given topically for cutaneous infections, and for the triazoles, they're given systemically for treatment or prophylaxis of cutaneous and systemic fungal infections.
Great. So
Also, they interfere with cytochrome enzymes, because even in the fungal cell, there's this specific cytochrome enzyme that they interfere with to prevent synthesis of sterols. And usually in humans,
it's 14 alpha sterol demethylase.
Yeah. So it's actually a cytochrome. It also interferes with, rather inhibits the cytochrome P enzymes in human beings. And ketoconazole is actually the most potent inhibitor of the cytochrome enzymes.
Nice. So azoles are CYP inhibitors, yeah, and ketoconazole, one of the potent CYP inhibitors. So that interaction definitely there. Black Panther also talking about azole antifungals. They are implicated in causing some hepatotoxicity, and also they can disrupt the heart rhythm and cause some QT prolongation. Yeah, especially when it comes even to a drug such as itraconazole, you don't want to give itraconazole to people with heart issues, because itraconazole also causes hypertension, and it has a negative inotropic effect, meaning it decreases the contractility of the heart. Yeah, just let me pick this. You all can go on.
And then ketoconazole, it has endocrine effects. Since Dr. Salman said it inhibits the cytochrome P450. So when it inhibits, it leads to synthesis of androgens. That's why it's used, the high doses of ketoconazole, it's used in Cushing syndrome to decrease the effects of, to decrease the what do you call it? The steroidal production, corticosteroid production in Cushing syndrome. So it decreases androgen production from the testes and displaces testosterone from protein binding sites. Yeah. It's clinically significant to reduce testosterone synthesis. High doses of it.
Nice. Yeah. So yeah, as a side effect, of course, the gynecomastia will come in if you're reducing testosterone synthesis. Yeah. Anyone else with something to add on azoles? Azoles are these are the major antifungal agents, even over the counter. These are the ones we give as first line all over. So anything else? Someone has something to add?
Don't know if it's mentioned that it's used for also vaginal candidiasis.
Yeah, fluconazole, yeah, the vaginal candidiasis, yeah, even the clotrimazole, the pessaries, yeah. So we can move.
Yes.
The next class, let's talk about the allyl amines. Majorly here we have the terbinafine, which is also another very common antifungal agent on the market. Terbinafine, or the allyl amines. The terbinafine, butenafine, and naftifine. Anything you know about terbinafine? Anything you know? They inhibit aldosterol biosynthesis by inhibiting the squalene epoxidase that is from Samiha. So she's told us the mechanism of action.
They are in dermatomycosis.
Go on. Sorry.
I was saying it's used in dermatomycosis, specifically onychomycosis.
Yeah, nice. Yeah. For fungicidal fingernails, and the dermatomycosis, especially the onychomycosis. Why onychomycosis? There was something we were saying about terbinafine and also griseofulvin. Why they were being used for stuff like onychomycosis. Onychomycosis for the nails.
They can penetrate the keratin cells in the nails.
Yeah, they can penetrate that, that keratin. Yeah, they are highly lipophilic. Nice. Maybe side effect, safety in pregnancy, tabenafil. Anyone with that information?
Terbinafine is CYP inhibitor. So it can form drug-drug interaction with something like rifampin. It can decrease the blood level of terbinafine. Looks for pregnancy. I can't see pregnancy. But it decreases the lymphocyte counts and neutropenia. It also elevates serum liver enzymes. And then it has some GI disturbances like diarrhea, nausea.
Okay, so side effects wise, nothing major. Diarrhea, nausea, headache, rash, nothing too. It's not that, it's barely toxic, right? So it's a very good drug. Someone in the chat box is also saying, yeah, there, CYP 450 inhibitors, yeah. Fungicidal used for infections of toenails and also infections of fingernails. What's the duration? I think this is unique in terms of treatment of the fingernails. What's the duration when you treat for the toenails, and what's the duration when you treat for the fingernails?
For the fingernails, I can see 1 week.
Really?
Yeah, duration is
Fingernails is usually 6 weeks and toenails are 12 weeks.
Yeah, because fingernails take time. They take time even for that approval to nini. So 6 weeks and 12 weeks. 6 for fingers.
And what I've found for toenails, like 3 months, and then 1 to 2 weeks after the infection has cleared. So you continue like 1 to 2 weeks after the 3 months of treatment. You continue for 1 to 2 weeks after it has cleared.
Nice, yeah. So after the infection has cleared, continue for 1 to 2 weeks. Just for good measure.
Someone said avoided in nursing mothers.
It should be avoided in nursing mothers. Okay.
For fingernails, it's 6 weeks, and for toenails, it's 12 weeks.
Next, we can go to the griseofulvin. I think, we'll cover griseofulvin as the last word. We'll have covered the major one. So griseofulvin.
Griseofulvin it's a class of, it's called heterocyclic benzofuran. Griseofulvin, and then it's obtained from Penicillium griseofulvum. And then the mechanism of action is it accumulates in newly synthesized keratin-containing tissue, then causing disruption of the mitotic spindle. They inhibit fungal mitosis. And The effective in athlete's foot. And then it's also used effective in tinea infections of the skin, hair, and nails. It says here it's given only for infections that do not respond to tropical antifungal agents. It's fungostatic and require a long duration of treatment, 6 to 12 months.
Is that for griseofulvin?
Yeah, 6
Yeah,
to
that's
12
true.
months. Actually, it's written here for this according to site of infection and the duration. For skull, 4 weeks. For palm and soles, 6 to 8 weeks. Fingernails, 6 to 8 months. Toenails, 10 to 12 months.
Okay.
Yeah, so you can see why terbinafine should be your go-to. Telling someone to take a drug for 12 months, it's a lot.
Yeah.
It says the duration depend on the site of infection. Yeah.
What website is that, Shafi?
It's Dr. Ermia's notes.
Ziko different na Medscape a bit, slightly, especially for the duration treatment.
Acha nitumie kwa group.
Medscape duration inasema how long?
Medscape duration for tinea anguium is 4 to 6 months. For pedis is 4 to 8 weeks. Tinea corporis and capitis is 4 weeks, 4 to 6 weeks basically, but for tinea capitis can go up to 12 weeks. Yeah. Shauna 12 months here. But also I think another important thing to know is the fatty meals. Absorption is increased with fatty meals for griseofulvin. Yeah.
And then I think it's category X for pregnancy.
Yes.
If I'm not wrong. Yeah. And
That's
then there are cytochrome P for 50 inducers. So if you combine them with like something like warfarin, it leads to decreased prothrombin time. There are some occasional ADRs like leukopenia, neutropenia, gynecomastia is reported, but it's very rare. Rash is hepatotoxicity is also rare. Rashes is also rare. So yeah.
Great. So yeah, so griseofulvin, fatty meals, good for it, take with milk, take with a fatty meal. Number 2, avoid alcohol, right? So you can imagine if someone has that toenail infection and they like partaking in alcohol, and you tell them for the next 12 months don't drink alcohol, they'll think you're not being kind to them. So, and then the other thing, the category X in pregnancy, that one is a no, because it's a highly teratogenic. Even for guys, if a guy has taken griseofulvin and they want to sire a child, you tell them to wait for 6 months, because it's even toxic to the sperms. So you can imagine how toxic griseofulvin is. Yeah. Anything else on antifungals? I feel like covering those major ampho-B, the azoles, and the terbinafine these are the major ones, unless someone has something, a burning issue. Antifungal.
Yes, griseofulvins cannot be given with oral contraceptives because it can cause amenorrhea or increase the breakthrough bleeding.
Ah, nice, nice. So don't give you the oral contraceptives. Remember, if I think Shafi has told us it's also a potent CYP inducer, so hey, don't failure of contraceptives is a very big deal.
Just
We go to the
I have a
next.
question. For the
Mhm.
polyins, are they CYP inhibitors as well?
Which ones?
Amphotericin B or
Though we didn't see it interacting with the CYP as much. Like there's no mention of CYP with ampho-B.
okay, so azoles are CYP inhibitors,
Yeah,
and also the amines are CYP inhibitors. Just
yeah,
griseofulvin is CYP inducer.
yeah.
Just we go on to the next question.
Irregardless, Shrina, irregardless.
Which of the following is a bacterial cell wall inhibitor? Ethambutol, fusic acid, systemic, fungal, rifampicin, or polymyxins?
So
I
question.
ethambutol. Ethambutol.
Yeah, ethambutol. Anyone else with a different opinion? Perhaps Hiral, you can be telling us the exact mechanism of action of ethambutol.
Ethambutol, it inhibits is it arabinosyl transferase, which is so when it inhibits this enzyme, it inhibits cell wall synthesis.
And now on that note, the mechanism of the other drugs listed here.
So second, the B-fusidic acid is I think a protein synthesis inhibitor. Rifampin is inhibits mRNA synthesis. And polymyxins, I'm not too sure. I just read that it disrupts membrane integrity. So I'm not sure if that is part of cell wall inhibitor or it's just like cell membrane integrity.
It's the cell membrane.
So the answer would be A, right?
Yeah.
Nice. I think
What did you say for B? You said it
protein synthesis inhibitor.
I think last time we looked extensively at management of TB, but we also mentioned the side effects, but we didn't look at the mechanism of action. So already the two drugs Hiral has said, ethambutol, the arabinosyl transferase, which are essential component of the cell wall. So once you inhibit that, you disrupted cell wall synthesis. Rifampicin, is it the DNA-dependent RNA polymerase? Yeah, that one is more on the synthesis of the nucleic acid. What about the other two, pyrazinamide and isoniazid? What are their mechanisms of action? The other two antitubercular drugs, major first-line antitubercular drugs. Pyrazinamide and isoniazid.
So isoniazid it inhibits.
Isoniazid. Go on, Idol.
Okay, it inhibits mycolic acid synthesis. So there's this whole and it also produces free radicals. So it damages the bacteria. And another mechanism is that it has this nicotinyl isomers, which now inhibit dihydrofolate reductase. So there are two mechanisms, or two, yeah, we can say it inhibits mycolic acid synthesis. Then from that you get these isomers. These isomers now inhibit dihydrofolate reductase, and they are also there's production of free radicals, so they damage the cell like that also.
And something unique about isoniazids, maybe as compared to the other antitubercular drugs, it's a prodrug, right? It's activated by that CAT-G.
Yeah, it's a prodrug.
Yeah, activated by the CAT-G. So resistance will be through that CAT-G mutation, so as not to activate the drug that kills it. Yeah.
And also,
someone else on pyrazinamide.
so another thing for isoniazid is that it's bacteriostatic for the resting bacteria, but if it's rapidly dividing cells, then it's bactericidal.
Nice. Yeah, it's bactericidal, but bactericidal against the growing. That's why HIV patients, if they have a latent infection at high risk of TB, you just give isoniazid alone, because it will make sure they do not multiply. Pyrazinamide. The side effects we had already looked at. The side effects we talked. Yeah, pyrazinamide.
So I think it's inactive, so it's first converted to pyrazinoic acid by the enzyme mycobacterial pyrazinamidase, and then this acid, the pyrazinoic acid, disrupts the mycobacterial cell membrane and the transport function.
Yeah, nice. Yeah. So it's first of all converted, and then it will disrupt the transport function, leading to, I think there's some extracellular leaking of hydrogen ions, and all that will impair the mycobacterial cell. Yeah. So someone with something to add on the anti-TB drugs, especially anything and pharmacology on the anti-TB drugs?
One of the ADRs for rifampicin is that it causes the red-orange urine.
Red-orange urine. Yeah. So yeah, you need to advise the patient with that.
And then pyrazinamide has several ADRs. It's hepatotoxicity. Then it also leads to hyperuricemia, since the pyrazinamide inhibits the excretion of ureates, resulting in hyperuricemia. And then it worsens for those people with gout. And then it's category D for pregnancy. It's very teratogenic. Yeah, those are the three ADRs of pyrazinamide.
Nice, thank you. category D, pregnancy. So in pregnancy, we'll just use the RHE. We won't use the Z. Do we move?
Oh, isoniazid is given with pyridoxine because of peripheral neuropathy.
Yeah, peripheral neuropathy. So we give that pyridoxine.
I think also, guys, ethambutol, it has some damage to visual acuity. It leads to red-green discrimination prior to start therapy. Like it diminishes the visual acuity.
Yeah, so you need before starting therapy, you need to know the visual acuity and keep monitoring it. Yeah.
This treating is right now. That's more than 10 buildings under construction.
So number 99, the drugs used to treat amoebiasis, giardiasis, trichomoniasis are classified into all the following except dichloroacetamides, aminoglycosides, 5-nitroimidazoles, pentavalent antimony compounds. So they are classified into all the following except. So amoebiasis, giardiasis, trichomoniasis. What is the one common thing we? Once you know that, the answer becomes so clear. Amoebiasis, giardiasis, trichomoniasis. What's the one drug that treats all? Yeah, metronidazole. The azole, can give metronidazole. Yeah, metronidazole, secnidazole. Those are zoles.
What were you asking?
Oh, I was asking what's the one drug that can treat all those three conditions?
Niko na swali. Example ya pentavalent antimony compounds ni kama gani?
Pentavalent antimonial, I think in sodium still gluconate.
Yeah, the pentavalent antimony compounds, they're usually used for leishmania.
Can you hear me? I've been told my internet is unstable.
Yeah, we can hear you now.
Yeah, so the answer becomes, as Hiral has said, the pentavalent antimony compounds, because those ones are used for leishmania, the sodium gluconate or gluconate. Yeah, then maybe we can just mention the other ones. The dichloroacetamide, here we have the diloxanide. And we know diloxanide is also used for treatment of amoebiasis. For aminoglycosides, we have the paromomycin. Paromomycin is also used for treatment of amoebiasis. Yeah, so the sodium cibogluconate has no use there. Had we discussed these things, their life cycle, their pathophysiology, especially amoebiasis before? The cysts, the trophozoites, all those funny things. Does
No, we didn't discuss.
entamoeba?
No, I don't think.
So in the chat box, I'm seeing that. Or what is the question? What's the life cycle of amoebiasis, of giardiasis, of trichomoniasis? Yeah. What's the life cycle? How do you get infected? What infect does it go? Nice. Thank you, Hiral. I'm seeing a very nice image of the group that the infected human, the environment, they'll release the cyst and the trophozoite. They can release both of them, the cyst and the trophozoite. The cyst is what you'll ingest. So it's a fecal oral mode of transmission. You'll ingest the cyst. Then once the cyst gets into the intestines, it changes into now the active life form, which is the trophozoite. And then, yeah, we know it can cause the intestinal disease, and then it can go now to things like the liver abscess in the lung, and even in the brain can cause abscesses there. Yeah. So amoebiasis, I think that unless someone has something to add, or pharmacy always thinks they have amoebiasis. I have nothing. We can nothing to add. We can continue to the next question.
I think somebody has put a image. I'm just trying to see if it's.
Nice. Let me download this.
Can the person put it on the group so it's easier?
Kind. Yeah. So it's those life stages. Yes. Yeah. Nice.
The thing. We have we have amoebiasis like classification, the one that attack the intestine, and the one that the extraintestinal. So under treatment, we have to target the luminal amoebiasis and the extra, that maybe you may target the liver or the liver. So under luminal, if you're sure that the amoeba has attacked only the luminal, so you only give paromomyxin, that's the aminoglycoside, and the loxanide. But if it's extra or mixed, we have both the extra intestinal and the intestinal. That's maybe you give the azoles, the imidazoles, the metronidazole, the tinidazole, and the secnidazole. But if it's extraluminal only, we give chloroquine.
So if it's, sorry, that last part, if it's extraluminal only, you give?
Chloroquine.
Ah, okay. Why, can I ask why not we just give the same nitroimidazole?
Okay, that's why like they always give because it's mixed up, like it's both the luminal and the extraluminal. You're trying to target both the sides. So that's why mostly we administer the imidazoles, the metronidazole, tinidazole, yeah.
And is there, when you said when someone has the intestinal amoebiasis, you said we give paromomycin, and you said and diloxanide. Is it and or?
Or actually, the
Or.
first line is diloxanide. Diloxanide is the first line. Paromomycin is alternative. The first line for intestinal is diloxanide. Yeah, you can both give them. They're effective for the luminal cysts and the trophozoite forms, both of them.
Thank you, Dr. Liz. Anyone with anything on amoebiasis? Or we move? Or on giardiasis, maybe you have a burning issue with giardiasis, something unique with giardiasis.
Let's just go on. Let's just giardiasis. Just say the treatment of giardiasis. The first line is tinidazole or nitazoxanide. That's the first line. The alternative are paromomycin and albendazole. And then for pregnancy, the first trimester, you can use paromomycin. The second trimester and the third trimester, metronidazole is the safest. Yeah.
Okay. Nice. While we're waiting for Shrina, and tell us how they differentiate trichomoniasis from vulvovaginal candidiasis. Which one of the following statements is false? Mebendazole is a benzimidazole. Praziquantel is a isoquinoline derivative. Albendazole is more toxic than thiabendazole. Niclosamide is a phenolic derivative. Which statement is false? May I go with C? Albendazole is more toxic than thiabendazole because there is no way we can be using a more toxic stuff, in my opinion. For once, OK has agreed with me that, yeah, she's also saying that the answer is C.
Yeah, the answer is C. But is niclosamide a phenolic derivative? I don't know about that, but the rest of the other two are. Oh, Samia said it is. Oh yeah. So the answer is C.
So something quick on the benzimidazoles, albendazole, mebendazole. What's their mechanism of action? Just their mechanism of action. I mean, albendazole is dished out everywhere in the market these days. MOA albendazole, MOA albendazole. What were ABZ? Let me see. Brenda loves selling ABZ. Yeah, so mechanism of action of ABZ. ABZ.
Has been sent to the group. It inhibits the beta microtubule protein.
Inhibition of the
polymerization.
The microtubules.
Polymerization inhibits the polymerization of microtubules.
Nice. And also Srina sent on how you can differentiate between yeast, bacterial vaginosis, and trichomoniasis and UTI. Yeah, don't be the paraprofessional who gives 5 antibiotics at once because you don't know what it is. So next paper, next question. We are on until 1. I think for the SAQs, we said SAQs will cover them when we are done with all the MCQs.
Okay, so just give me like 2-3 minutes to download the papers, or if somebody has, they can start.
Take your time, Shina. Take your time. Let me pause the body.
Which one of the following statements is true about hypothalamus? It forms a part of the midbrain, has a nerve connection with the anterior lobe of the pituitary gland, contains the tuber sacrum, and forms part of the roof of the third ventricle.
I would go with B.
Method A and B are out.
Is it false or true?
It's asking which one is true. Oh, yeah, which one is true? Yeah, true, right? But is it a nerve connection to the anterior pituitary gland? Because see, when we were discussing, we said it's there's that what is it called, capillary connection. The nerve connection is with the posterior pituitary gland. I stand corrected, but I think
Yeah,
B
it's not way.
false based on that. Where's our physiology expert? Dr. Karemi. Where is she? She's not here today. She is. Daktari. I don't know if she's in a position to unmute. Maybe she's at work.
Okay,
But,
good afternoon, Doctor. Thanks. I'm available, but a bit caught up. But looking at B, you usually say that the hypothalamus, you have the adenohypophysis and neurohypophysis. So adenohypophysis is the anterior pituitary, so and neurohypophysis is the posterior. So the nerve connection is for posterior, not anterior. Thank you.
thank you. So I think the Black Panther has confirmed that it contains the tuber synchra, but that is true.
I think C is true too, because I don't think it forms part of the roof of the third ventricle.
So D is false. Yeah. The lateral walls. Yeah, the hypothalamus forms the lateral walls of the third ventricle. So that makes C the correct answer, the true statements.
Serena,
Yes, sorry. Yes, tell me.
we said C is the correct answer.
Only C is true. Okay.
Yeah. It doesn't form part of the midbrain, and then it forms nerve connection with the posterior, not the anterior. And then for this other one, guys said it's what? I beg pardon that, guys.
On choice D, it forms the lateral wall of the third ventricle, not the roof, the wall, the lateral wall.
Yeah.
And then, which one of the following hormone is secreted by the posterior pituitary gland? These things we had covered in detail. That's why we are not focusing a lot on hypothalamus and pituitary. Anyway, so for that one, OK has said that it is oxytocin. And she's gone ahead to say that the posterior pituitary gland also produces vasopressin, also known as ADH. Okay, so which one of the following is not a function of angiotensin 2? Then for this one, we had covered the RAS system in detail. So which one is not a function of angiotensin 2? Yeah, so for number 9, they're saying that vasodilation is not a function of angiotensin 2. The consensus is that angiotensin 2 is a vasoconstrictor. So angiotensin 2 will do what? Let's of aldosterone. It will reduce renin release from the kidney. Remember the negative feedback inhibition. It will also increase plasminogen activator. It will increase the plasminogen activator. Shrina, we've gone with number 9, we've gone with choice C.
For number 10, I think the answer is skin because they're found in the tummy. Yeah, I think 11 and 12. What you've marked, Shin, I think they're okay, unless anyone has a dispute. Number 13, how many possible phenotypes are there for ABO blood group? Is A, B, O, and AB. So that's 4. Yeah. Yeah, in the chat box, they agree. For number 14, the creation of mutation is called what? Mutagenesis. Think from the name. Number 15. Wait, who knows what saltatory changes are?
Okay. I think for immunoglobulins, we had discussed last time their structure and all. 16 is E, not D. D is at least, so the highest we have is IgG, followed by A, M, D, and E. The easiest way to remember how they form is, the concentration is that's when just a way to remember how they are found in the concentration.
So A is the highest in the concentration.
IgG is the highest.
G is the highest, followed by A, M, D, and then E.
Yeah.
Okay.
Are we all exhausted, or so don't know if we should start meet at 5 or we continue?
We
think we
continue from
continue.
here tonight, please.
The next meeting is at 5 o'clock.
Yeah.
Okay. So I guess we can meet at 5 then.